Neurosurgery Part 1 Scalp, Skull and Brain. Anatomy of the scalp. The scalp is made of soft structures that cover the skull, extension from one temporal to the other, and from the eyebrows to the superior nuchal line. Layers. SCALP, abbreviation scalp. S for skin. C, connective tissue containing blood vessels and nerves of the skin. A, aponeurosis, Gallia aponeurotica, which contains occipitofrontalis muscle, 2 pairs of bellies, frontal and occipital. Loose areolar tissue containing few blood vessels. P for pericranium. This is the periosteum on the outside of the skull. Scalp injuries. Wounds of the scalp include contusions, hematomas, lacerations, or incised wounds, characterized by healing rapid. Bleeding is very profuse up to shock, caused by sharp or blunt instruments or falls on the head. If infection occurs in loose areolar tissue, it leads to extensive cellulitis. Management. If there is a possibility of a skull fracture, do plain skull X-ray. Closure in 2 layers, Gallia to Gallia by absorbable sutures, skin to skin by non-absorbable sutures. If there is a liability to infection, close in 1 layer of loose sutures. When there is a scalp defect, do rotational flap. Infections of the scalp. Etiology. Secondary to wounds. An abscess may occur in the subcutaneous tissue, subgallial or subperiosteal layers. Intracranial extension of infection may occur from the subgallial area by the emissory veins. An infected sebaceous cyst is commonly seen in the scalp. Treatment, antibiotics according to culture studies, and abscess should be drained. Tumors of the scalp, benign, locally malignant and malignant, benign lipoma, papilloma, plexiform neurofibroma, hemangioma, cricoid aneurysm, locally malignant, basal cell carcinoma, malignant, epithelioma, melanoma, fibrosarcoma, sebaceous adenocarcinoma, and metastasis. Anatomical facts. Scalp is rich in blood vessels, so the wounds heal nicely and without infection. Arteries present in the subcutaneous layer are adherent to the fibrous tissue of this layer. When a vessel is injured, the muscular coat of the divided artery cannot retract, leading to profuse bleeding. Skin, subcutaneous tissue, and epicranial aponeurosis are firmly attached to each other, but loosely connected to the pericranium by loose areolar tissue, leading to complete avulsion of the scalp, which can occur. Loose areolar tissue layer allows accumulation of large amounts of blood or inflammatory exudate. Then we have comparison between the hematomas of the scalp. We have subcutaneous, subgallial, and cephalohematoma or subcranial, subpericranial. Subcutaneous hematoma of the scalp. The cause is direct blow, level, subcutaneous connective tissue. Clinical picture, small, painful, moving with scalp over the skull. Treatment, resolves spontaneously. Subgallial hematoma of the scalp. Cause, direct blow, level, under gallia. Clinical picture, large, soft, fluctuating swelling, reaching to the suborbital ridges anteriorly and to the nuchal lines posteriorly and laterally to the temporal lines. The scalp floats over the swelling. Treatment, aspiration and pressure bandage. Cephalohematoma or subpericranial. Cause, head injury during delivery. Level, under periosteum. Clinical picture, hematoma limited by suture lines to the underlying bone, usually parietal. How to stop bleeding from a scalp wound. Direct pressure. Exclude first depressed fracture. Applying multiple Alice forceps to the edge of the wound and bending them, applying multiple artery forceps to the Gallia aponeurotica and allowing them to fall back over the skin edge. All these measures are temporary before suturing the wound. Skull, tumors of the skull, benign and malignant. Benign, ivory osteoma occasionally arising from the frontal sinus. Malignant, they are either primary or metastasis, primary osteosarcoma, fibrosarcoma, giant cell tumor, and multiple myeloma. Metastasis from the breast, thyroid, adrenals, kidney, and prostate. Skull fractures divided into vault and base. For the base, we have anterior, middle, posterior fossa, and vault, fissure, or depressed. Fissure, closed or open. Depressed is closed or open. Fractures of the vault. Etiology, direct localized blow over small skull area, closed or compound depressed fractures. Compression by a hard flat surface, leading to fissure or linear fracture. And finally, we have the missile injuries. Clinical picture, a fissure fracture, clinical picture of associated cerebral damage. Depressed fractures, closed, rare in adults, associated with overlying hematoma, may obscure the fracture. The depressed segment rarely causes cerebral compression. Compound, they may be profuse bleeding, leakage of CSF, or brain prolapse. Concussion is surprisingly slight and usually no compression. The main hazard here is the liability to infection. Investigations, plain X-ray to reveal the fracture. Differential diagnosis from the suture line of the skull exists at certain sites and has serrated edge. Complications of a depressed fracture, dural tear leading to brain prolapse, infection leading to osteomyelitis or meningitis, epilepsy, early or late, elevation of the depressed segment may reduce but not prevent this complication, cosmetic deformity, and severe bleeding from any venous sinuses. Treatment: for fissure fracture, treatment of associated cerebral damage. If present over the course of middle meningeal vessels, the possibility of an extradural hematoma is there. If the fracture is compound, treat the scalp wound. Depressed fractures, closed, essentially by conservative measures. Indications for surgery to raise the depressed fracture: long depressed segment more than 1 inch with possibility of a dural tear, compression of an important area as motor or speech center, cosmetic deformity as in frontal bone, or if the fracture is overlying an air sinus. Compound, operated upon in theater under absolute aseptic precautions, such as foreign bodies are removed, elevate the depressed segment gently to avoid dural tear, suck any prolapsed or necrotic brain tissue, do hemostasis, any dural tear is repaired, removed bone segments are cleansed and replaced, the pericranium and scalp are sutured, prophylactic antibiotics are administered. Fractures of the base, whether indirect trauma or direct trauma. Indirect trauma, most common, falls or blows on the vault, leading to compression of skull at one area and giving way of the skull in the opposite. A vault is elastic, so it escapes, while the base, being rigid, is weakened by multiple foramina, so it breaks. Sometimes fracture starts in the vault and extends to the base. Direct trauma, due to penetrating sharp objects or bullets. Clinical picture: anterior fossa, there is escape of intracranial contents, such as blood and CSF, and brain matter. Brain matter may escape into the nose or the pharynx. CSF, rhinorrhea, if dura is torn and cribriform plate is fractured. Persistent salt taste due to high chloride content. Air may enter cranial cavity when the patient blows his nose, leading to something called pneumocephalus. For the blood, epistaxis if cribriform plate is fractured. Lead ecchymosis, panda bear or raccoon sign if orbit is fractured, distinguished from ordinary black eye by there is no bruising of the skin around the orbit, and the effusion occurs several hours after the injury and commences in the lower lid before the upper lid. Extravasation occurs into tissue at back of the orbit, leading to pushing of the eye forwards, and extravasation may prevent ocular muscle action, leading to limitation of eyeball movements. If it extends in the subconjunctival space, the patient can see its posterior limit. The doctor can see its posterior limit. Differential diagnosis from subconjunctival hemorrhage due to direct trauma. Cranial nerve injury, olfactory nerve, if unilateral, unrecognized partial anosmia. The optic nerve usually escapes. Fifth nerves may be injured at the sphenoidal fissure. Serve nerve palsy, a dilated pupil in a conscious patient. Associated brain injury, concussion, usually severe. Essential clinical features: escape of cranial contents such as blood, CSF, or brain matter. Injury to the cranial nerves. All cranial nerves are liable to be injured except for the 12s because the condyloid foramen is protected by a ridge of bone which deflects the line of fracture into the foramen magnum. Associated brain injury, depending on the fossa involved, they are often compound fractures and the risk of infection is high. For the middle fossa, escape of intracranial contents. For the blood, from the ear, the most common and characteristic side. Differential diagnosis from bleeding of ruptured drum. Epistaxis if fracture involves the nasal sinuses commonly. Sphenoidal, leading to cavernous sinus and carotid artery injury. Post-auricular ecchymosis, called battle sign. CSF, otorrhea. Scalp emphysema around the ear if mastoid air cells are affected. Cranial nerve injury, the facial nerve, common. 8th, 6th, 2nd, and 3rd divisions of the 5th nerve. Concussion with signs of severe intracranial damage. Posterior fossa, extravasation of brain contents. Blood in the suboccipital region leading to a boogie swelling on the nape, and nape discoloration. External hemorrhage doesn't occur because the fracture is rarely compound. Cranial nerves injury, 9th, 10th, and 11th. Hypoglossal nerve usually escapes, which is the 12th. The upper cervical nerves are sometimes irritated by blood, leading to head retraction and stiffness of the cervical muscles. Associated brain injury, pons and medulla may be injured, leading to deep unconsciousness. Subtentorial hemorrhage, leading to bulbar compression and death. Blood from tympanic membrane clots rapidly, but blood mixed with CSF continues to drip for several days without clotting. Facial nerve injury can be either injured at the time of the accident, leading to permanent paralysis, or paralysis appears after few days from compression by extradural hemorrhage, often recovers. paralysis developing some weeks after injury due to pressure from fibrous tissue or callus, which is permanent. Treatment: prevention of infection. Prophylactic antibiotics started at once, continued for 1 week after cessation of bleeding or CSF leakage. Avoid mouth or ear washes, increases the risk of infection. When the ear is involved, sponge daily with cotton wool. Controlling CSF leakage, semi-sitting position, usually stops in 85% of rhinorrhea and 95% of otorrhea. Surgical dural repair if discharge persists for more than 10 days. Treatment of the associated brain injury. And then we have intracranial injuries. Etiology: blunt injuries, low velocity as in falls, and high velocity as in road traffic accidents. Penetrating injuries as in missiles. Factors affecting severity of cerebral injuries: brain distortion, mobility of the brain in relation to the skull and membranes, configuration of the interior of the skull, age of the patient. A young patient, better chance of recovery. Configuration of the interior of the skull, smooth skull areas leading to less damage. Temporal lobe may be damaged by sharp sphenoid ridge, and the frontal pole by the rough floor of the anterior cranial fossa. Mobility of the brain in relation to the skull and membranes as in acceleration or deceleration injuries. Brain distortion, posterior displacement leading to distortion hypothalamus and brainstem, affecting reticular formation, leading to loss of consciousness. Anterior displacement leading to distortion of the corpus callosum, widespread damage to neurons, nerve fibers, glia, and blood vessels. The main factor which leads to most of the head injuries is cerebral tissues displacement and distortion at the moment of impaction. Factors raising the intracranial pressure in patients with head injury: brain edema, intracranial hematoma, extradural, subdural, or intracerebral, cerebral swelling due to local vasodilatation and loss of autoregulation, rise of arterial carbon dioxide. Cushing triad is decreased pulse, decreased respiratory rate, and elevated blood pressure. Pathology of intracranial injuries. We have primary pathological sequelae and secondary sequelae. For the primary, we have cerebral concussion, cerebral contusion, and cerebral laceration. Cerebral laceration: the pia and arachnoid are torn with bloody effusion of the CSF. Cerebral contusion: areas of bruising and swellings with localized or generalized edema and hemorrhage due to tearing of blood vessels. The pia and arachnoid are intact. Clinically, prolonged period of unconsciousness and on recovery, leading to headache, photophobia, and confusion. Physical signs of focal neurological damage. Cerebral concussion: slight brain distortion without any organic structural damage immediately after the injury, leading to temporary loss of consciousness. Manifestations: relaxed muscles, rapid weak pulse, respiration is shallow and slow, rounded pupils, regular and reactive, reflexes are absent or sluggish, lasting from few minutes to few hours, leading to complete recovery. Secondary pathological sequelae: brain edema, intracranial hemorrhage, and vascular changes. Vascular changes: intracranial pressure increases, disturbing the cerebral blood flow, leading to ischemic necrosis and brain edema. Intracranial hemorrhage: arterial or venous bleeding, leading to intracranial hematoma, which may be extradural, subdural, or intracerebral. Severe trauma, leading to many small vessels tearing. Deep intracerebral hematoma with serious brain damage, edema, and necrosis. Brain edema: intracerebral or extracellular fluid accumulation, may be localized around the area of brain injury, or it involves the whole brain, leading to marked rise of the intracranial pressure. Clinically, it simulates brain compression due to hematoma, but without focal manifestations. Cerebral infusion pressure equals mean blood pressure minus intracranial pressure. Herniation: tentorial herniation or foramen magnum herniation. Tentorial herniation: herniation of the medial part of the temporal loop on the side of the supratentorial mass, leading to compression of oculomotor nerve, constriction, then dilatation of the ipsilateral pupil and midbrain, and descending motor pathways from the opposite hemisphere, leading to hemiplegia on the same side of hematoma. Foramen magnum herniation: herniation of infratentorial compartment, leading to compression of vital centers in medulla, decreasing pulse, respiratory rate, and elevating blood pressure, which is called Cushing triad, with severe headache and neck rigidity. Brainstem injury: primary damage or secondary to unrelieved supratentorial hemorrhage. Clinically, unconsciousness with extension spasms in all limbs, opisthotonus, tachycardia, small pupils, pyrexia, rapid shallow breathing. With intensive treatment, recovery but with marked spasticity. infection in patients with compound fracture or fractures of the base, especially if there is CSF rhinorrhea or otorrhea. Complications: meningitis 2 to 3 days after injury, fever and neck stiffness, differential diagnosis from the subarachnoid hemorrhage by lumbar puncture and brain abscess, CSF rhinorrhea secondary to fracture involving the sinuses associated with a dural tear, liable to be followed by meningitis. Treatment: antibiotics initially. Indications for surgical interference: occurrence of meningitis, persistence of rhinorrhea more than 10 days, and presence of a fracture involving frontal and ethmoid sinuses. Extracranial factors which affect cerebral injury: respiration, blood volume and blood pressure, fluids and temperature. Rise in body temperature leading to increasing metabolic demands and metabolites accumulation leading to neurological state deterioration. Fluids: cerebral injury leading to blood-brain barrier disturbances and inappropriate ADH secretion. IV infusion of hypotonic fluids. Here, lower plasma osmolarity, increasing brain edema and swelling. Blood volume and blood pressure. Hypovolemia decreases cardiac output leading to irreversible cerebral ischemia damage. Respiration: respiratory inadequacy leading to hypoxia and increased carbon dioxide, leading to severe brain edema and venous congestion, leading to irreversible changes. Acute extradural hematoma. Etiology: trivial trauma on the side of the skull, leading to fracture of the temporal or parietal bone. Source of bleeding: MMA, middle meningeal artery, 50%, middle meningeal vein bleeding. Pathogenesis: blood will pass in 3 directions: outwards, upwards, and downwards. Outwards, a boogie swelling under temporalis muscle, upwards over the parietal region, downwards into the middle fossa. Clinical picture: 3 stages: stage of concussion, stage of lucid interval, and stage of compression. Stage of concussion: mild blow to the head leading to brief period of concussion. Stage of lucid interval: the patient recovers from the initial concussion, resumes his activities, during which blood accumulates gradually in the extradural space. If the source of bleeding is venous, the lucid interval will be longer. Stage of compression: gradual deterioration of consciousness leading to confused, irritable, and later drowsy, semi-comatose or comatose with snoring. Compression of the ipsilateral cortex leading to contralateral hemiparesis. Tentorial herniation: compression of oculomotor nerve constriction followed by dilatation of the ipsilateral pupil. Later, contralateral pupil will constrict and then become dilated. Continuous tentorial herniation: compressed crus against rim of tentorium, leading to hemiparesis on same side of hematoma. As coma deepens, blood pressure rises while pulse and respiration slow down. Terminal stage: hyperpyrexia, decerebrate rigidity, and bilateral dilated fixed pupils. An extradural hematoma can occur without a skull fracture in children as they have elastic skull. Acute intracerebral hematoma incidence: the least common. Clinical picture: usually accompanied by brain contusions, laceration, edema, necrosis, and poor general condition. Investigation: CT scan. Prognosis: poor. Acute subdural hematoma. Etiology: usually severe blow to the skull, rupture of a large vein as it crosses subdural space to reach the fixed subdural venous sinuses. Cortical laceration less commonly. And we have a comparison in the clinical picture between acute extradural hematoma and acute subdural hematoma. Regarding the trauma, brain damage, lucid interval, acute extradural hematoma is of mild trauma, mild brain damage with presence of lucid interval, while the acute subdural hematoma, severe trauma, severe brain damage with absent lucid interval. Acute extradural hematoma for the CT scan, usually unilateral, the brain side is convex, density usually uniform, and the brain is normal, while in acute subdural hematoma, commonly bilateral, with concave for the brain side, density less uniform, and the brain having edema. The prognosis of acute extradural hematoma is good with early surgery, while in the acute subdural hematoma is bad and mortality exceeds 50%. Management of intracranial injuries. Dealing with life-saving priorities: protection of the airway, this is the most serious step, maintenance of adequate breathing, arrest of hemorrhage, correction of shock, most likely due to internal hemorrhage in the thorax or abdomen, initial examination, vital signs, pulse, blood pressure, respiratory rate, scalp for any scalp wound or hematoma, skull for any fracture, assessment of level of consciousness by Glasgow Coma Scale. The higher the score, the better is the prognosis. Classification according to the scale into mild, moderate, and severe. Mild 13 to 15, moderate 9 to 12, and severe equals to or less than 8. It's divided into eye response verbal and motor. For the eye, we have 4 points: 1, none; 2, to pain; 3, to speech; 4, spontaneous. For the verbal, we have 5 points: 1, none; 2, incomprehensible sounds; 3, inappropriate words; 4, confused; 5, oriented. For the motor, we have 6 points: 1, none; 2, abnormal extension, decerebrate rigidity; 3, abnormal flexion, decorticate rigidity; 4, flexion, withdrawal; 5, localizing pain; and 6, obeys commands. The majority of patients with cerebral injury will need only conservative measures, not surgical interference. Unnecessary surgery worsens the condition. Many extracranial factors such as blood, volume, oxygen, carbon dioxide, and temperature have serious impact on the injured brain. After assessment of consciousness, we go for the pupils. Examine both for their size, reaction to light. Immediately dilate a pupil after the accident equals direct orbit or oculomotor nerve injury. Constricted pupil on initial examination and later dilates leads to lateralization due to supratentorial hematoma. Limbs. Examine for any fracture or vascular injury. Hemiplegia in acute phase is likely to be due to primary cerebral damage rather than due to compressing intracranial hematoma. Chest. For fractured ribs, pneumothorax, hemothorax. Abdomen. Examine for internal hemorrhage or peritonitis. Back. For the possibility of fractures or dislocations. The most important sign of patient's progress is the level of consciousness. CT scan should be done before surgery to evaluate the size of the hematoma and degree of brain damage and edema. If the patient is in urgent need for evacuation of an intracranial hematoma, no time should be lost in doing investigations and surgery should be done immediately. Indications for admission to the hospital: skull fracture, focal neurological signs, persistent headache or vomiting, depression of level of consciousness, absence of responsible relatives who can observe the patient for the first 24 hours, difficulty in assessment of the patient, whether alcoholic, young, or epilepsy. Investigations done after the patient is resuscitated and stable. Plain skull X-ray, site and type of the skull fracture, and foreign body can be visualized. CT scan is highly recommended for depressed or compound fractures, impaired level of consciousness or focal neurological signs, basal skull fractures, seizures, deterioration of level of consciousness, and vomiting more than once. CT scan will detect brain edema, brain contusion or laceration, assess site, size, progress of intracranial hematoma. Acute extradural or subdural hematomas are hyperdense compared to the brain, with shifting of the midline structures. Continuing care and observations. The aim of conservative treatment: give the patient maximum care until spontaneous recovery, detect complications as early as possible, attention to airway, and if spontaneous respiration is inadequate, to keep normal levels of oxygen and carbon dioxide, insert an endotracheal tube which needs full sedation or muscle relaxants. It can be left up to 7 days. If ventilation is needed for a longer period, do tracheostomy. Any patients with Glasgow Coma Scale equals to or less than 8, it needs intubation. Foley catheter is inserted to estimate urine output. Frequent change of posture to avoid bed sores. Physiotherapy to the joints and massage to the muscles. Nasogastric tube inserted for feeding. Osmotic diuretics to raise the plasma osmolarity. Reduce brain edema. Method: 250 milliliters of 20% mannitol over 20 minutes and may be repeated every 8 hours. Shouldn't be used for more than 48 hours to prevent rebound edema and electrolyte disturbances. Before giving mannitol, exclude intracranial hematoma and check that the renal function is satisfactory. Furosemide 40 to 80 mg intramuscular is an alternative to mannitol. Repeated observations for the following: pupils, pulse, blood pressure, temperature, level of consciousness using Glasgow Coma Scale, respiration and reflexes, causes of deterioration of the patient, brain edema, increased intracranial tension, airway obstruction and or hypoventilation, leads to brain swelling and increased intracranial tension, respiratory insufficiency confirmed by estimating oxygen and carbon dioxide, intracranial hematoma confirmed by CT scan, fever due to respiratory infection or meningitis, overtransfusion by hypotonic fluids or dehydration, and finally epilepsy. Corticosteroids are empirically prescribed, but there is no evidence that they reduce cerebral edema nor improve outcome in severe head injury. If epilepsy is not accompanied by convulsions, it's difficult to differentiate it from intracranial hematoma. A high intracranial pressure is caused by hematoma or cerebral edema. CT scan can easily diagnose the presence and site of intracranial hematoma. And the final step, we have surgery to evacuate acute intracranial hematoma. Early evacuation before deterioration and fatal herniation of the cerebellar tonsils and medulla through the foramen magnum occurs. Rising intracranial tension produces the following manifestations: slow pulse rate, rising blood pressure, slow respiratory rate, and deterioration of the level of the consciousness. Operation. Under general anesthesia with endotracheal intubation, the patient is placed supine with the site of hematoma uppermost and the head is raised slightly to reduce venous bleeding. A formal craniotomy by an osteoplastic flap is done. The flap includes skin, temporalis muscle, and part of the skull. 4 or 5 burr holes are done and are connected by a saw. Skin and temporalis are not dissected from the bone. The osteoplastic flap is turned down to expose dura. If an extradural hematoma is present, removed by suction, and MMA is coagulated or underrun by a stitch. Occasionally, it may be necessary to follow the MMA to the foramen spinosum, which is packed with bone wax. If subdural hematoma is found, open the dura mater in a cruciate fashion, rapid decompression of the brain, and drain is placed and the flap is returned to its place, fixed by suturing temporalis, fascia, and skin. Prophylactic anticonvulsant drugs are prescribed for 6 weeks. Late complications of head injuries, chronic subdural hematoma, incidence, elderly and alcoholic secondary to slight blow to the head which may pass unnoticed, bilateral in 50% of cases, pathogenesis, sudden brain displacement leading to rupture of superior cerebral veins as they pass to the venous sinuses, collection of blood in the subdural space. Cerebral atrophy in elderly persons and alcoholics make brain displacement easier. Clinical picture, symptoms, appears weeks to months after trauma, vague and consist of chronic headache, mental apathy, slowing of cerebration and even stupor. Signs may be absent, may be unilateral or bilateral extensor plantar response. Pupillary changes, late and denote impending conization, may be diagnosed as psychosis or cerebrovascular accident. Investigations: CT scan, hematoma which is hypodense compared to the brain. Fundus examination papilledema is exceptional. Treatment by evacuation through burr holes. Continuing late complications of head injuries, we've mentioned chronic subdural hematoma. Now we're gonna discuss post-traumatic headache with serious head injury. Some residual as headache, giddiness, impaired sleep, and defective concentration occur. These patients need prolonged convulsions. Post-traumatic epilepsy may be either early, within 1 week after the injury, especially depressed fracture or intracranial hematoma, need prophylactic anticonvulsants for 6 weeks. Late epilepsy with 1 to 4 years after injury, incidence is much higher in those who had early epilepsy. Treatment is by long-term anticonvulsant drugs. Post-traumatic hydrocephalus may need shunt operation. Intervertebral disc prolapse etiology: sudden strain 80%, the annulus ruptures, nucleus pulposus protrude, degeneration of the annulus in 20% level. In the most mobile segments of the spine, 80% in lumbar region, particularly L4 and L5 or L5 and S1, 19% in cervical region, particularly C5 and C6, and C6 and C7 direction, posterolateral, compressing nerve roots, posteriorly, compressing spinal cord, and into the vertebral body, leading to something called Schmor's node. Lumbar disc prolapse, clinical picture: low back pain, root pain, motor and sensory changes, straight leg raising and scoliotic position and limping. For low back pain, typically while lifting a heavy object, spinal muscles go into painful spasm, leading to inability to straighten up. Root pain etiology: nerve roots compression, radiation down the back of the lower limb increases by cuffing. Motor and sensory changes: L4, L5 disc prolapse, motor, weakness of the ankle dorsiflexion, sensory, pain and anesthesia of the back of the thigh, lateral aspect of the leg and dorsum of the foot. L5, S1 disc prolapse, motor, weak plantar flexion of the ankle and absent ankle jerk, sensory, pain and anesthesia of the back and of the back of the leg and sole of the foot. Scoliotic position and limping gait to reduce nerve root pressure. Straight leg raising or flexion of the spine increases pain. Intravertebral disc anatomy composition: central nucleus of a jelly-like substance called nucleus pulposus, enclosed by fibrous ring, the annulus fibrosus, the whole being enclosed by 2 fibrocartilaginous plates above and below. The function: shock absorbent and allow normal mobility between adjacent vertebrae. Investigations of lumbar disc prolapse: plain X-ray of the spine, postural, anterior and lateral view, disc space narrowing. In chronic cases, osteophytes at the margins of the vertebrae, and to exclude bone diseases with similar manifestations, CT scan and MRI accurately localize the site of the disc prolapse. Treatment: conservative and surgical. Conservative: rest in bed on boards placed under mattress to give rigid support for 2 to 4 weeks, relieving pain in the majority of cases. Analgesics and anti-inflammatory agents. Physiotherapy after recovery from the acute attack. Weight reduction and avoidance of sudden flexion strains on the spine. Surgical treatment and cases. Persistence of symptoms. Recurrent attacks of severe pain. Evidence of motor or sensory affection or sphincter weakness. Aim: to remove the prolapsed nucleus pulposus. Approach: laminectomy through vertical midline incision in the back, or microdiscectomy by incising tissues between adjacent laminae, can be done by endoscope. Causes of pain recurrence after surgery: removal of a disc from the wrong level, presence of another undiagnosed disc prolapse, presence of interstitial neuritis due to prolonged compression, osteoarthritis of the intervertebral disc, intervertebral joints leading to spinal fusion should be performed during the operation for removal of the disc. Cervical disc prolapse, lateral protrusion, compression of half of the spinal cord leading to something called Brown-Sequard syndrome, and compression on nerve roots depends upon the disc level. If C5 and 6 disc compression, motor, weakness of biceps, diminished biceps and supinator jerks, sensory pain and anesthesia over the outer border of the arm and dorsum of the forearm. C6 and 7 disc compression, motor, weakness of finger extensors and diminished triceps jerk, sensory pain and anesthesia over back of the upper arm and forearm. Movements of the spine aggravate the pain, while rest and traction of the spine alleviate it. We also have midline protrusions, compression of anterior part of the cord leading to quadriplegia, compression of anterior spinal artery affecting pyramidal and spinothalamic tracts. Treatment: conservative, a collar to limit movements of the neck, and in severe cases, traction of physiotherapist for about 20 minutes every day. And finally, analgesia. If there is evidence of cord compression with developing quadriplegia and urinary incontinence, urgent decompression by laminectomy followed by spinal fusion should be done. Spondylosis. Definition: degenerative condition, often a part of generalized osteoarthritis. Many of the symptoms and signs of spondylosis are similar to disc prolapse. An element of disc prolapse is common feature of spondylosis. Clinical picture: stiffness, limitation of movement, and pain in a nerve root distribution. Investigations: X-ray, osteophytic lipping of the edges of the vertebrae, osteophytes particularly around the vertebral foramina, and narrow disc spaces. Treatment: similar to disc prolapse, conservative and surgery. Conservative: analgesia as anti-inflammatory agents. Mild cases: physiotherapy to strengthen spinal extensor muscles. Spine support, traction for varying periods may be valuable. Lumbar spine, abdominal corset with steel stays or plaster jacket in a few severe cases. And cervical spine, we have cervical collar. Surgery indications: severe persistent symptoms, evidence of advancing nerve pressure. Operation: laminectomy for decompression followed by spine fusion with bone grafts. Spine tumors: extradural tumors, intradural extramedullary tumors, and intramedullary tumors. Extradural tumors, pathological types: secondary deposits, the commonest source, thyroid, breast, lung, kidney, prostate cancer. Nature: osteolytic except in cancer prostate, osteosclerotic, sarcoma, chordoma, neurofibroma, and maybe dumbbell in shape. Clinical features: symptoms and signs of irritation of nerve roots followed by pressure manifestations. Brown-Sequard syndrome: there is weakness and loss of vibration on the same side as the lesion and loss of pain on the opposite side. Complications: paraplegia if pressure is not relieved. Intradural extramedullary tumors. Pathological types: the most important are meningiomas and schwannomas. Clinical features: sensory and motor weakness depending on tumor site, and symptoms due to pressure on the cord itself occur later in hemisection compression called Brown-Sequard syndrome. Intramedullary tumors, gliomas or ependymomas. Clinical feature: cord signs present first, while root pain tend to occur later. Paralysis may occur on both sides, sometimes cross anesthesia on one side and paralysis and hyperthelia on the other. Dissected sensory loss and urinary incontinence. Investigation: CT scan and MRI, plain X-ray of the spine, bone erosion or other bony abnormalities in nearly 50% of the patients. Treatment: tumor removal and laminectomy to form cord decompression. Most frequent site of Pott's disease is dorsolumbar fracture, dorsolumbar and cervical, spina bifida, lumbar, disc prolapse, lumbar L4-5, L5-S1, and cervical C5-6, C6, C7. And finally, we have something called spondylolithiasis between L5 and S1. And this concludes our part for the neurosurgery for today.